So I'll be showing a couple of case examples to emphasize the clinical utility and the importance of fulfilled ERG. So like fulfilled ERG is the mass response of the retina to luminance stimulus. This word is important, okay, because in the other ERG may be using the different patterns. So once you stimulate the retina, so there will be biochemical and ionic changes in the photoreceptor and RPE, which generates electric potential, which is recorded as fulfilled ERG. This is a response from the entire retina. So I'll just take you through some of the case examples where there is some uncertainty about what's happening, what is intended and what is required. So coming to the night vision problems. So this was a 26-year-old male who presented with night vision problem. So the fundus basically it appeared normal and OCT all the layers were intact. It was basically it was normal macular OCT. So when you did the ERG, just look at the dark colored responses. It's almost like unrecordable, and also the combined responses were diminished. The photopic responses were relatively okay, though they were diminished. So any 26-year-old male presenting recent onset of night vision problem, structurally things are intact and ERG showing these kind of changes, the next thing I will do is get a serum vitamin A level done. As expected, it was low in this patient. So it doesn't end there. We need to find out why is it low. So on general physical examination, he was malnourished. When we probed, he gave history of dyspepsia and frequent loose stools and all that. He underwent extensive workup to identify the cause for this malabsorption. So finally, he had to go and intestinal biopsy where there were features suggestive of intestinal leukoproteinosis. So the ERG was repeated after 1 week, 1 month and 2 months after receiving an intramuscular dose of vitamin A. So this is the serial ERG monitoring at the presentation. If you just look at the dark colored responses, by the end of 2 months, it became normal. Okay. So there are some avoidable, treatable cause of night vision. You need to pick it up. So especially if the patient is around 46, if there is a recent, if there is a chronic alcohol, and if you are examining, if you see a tinge of icterus in the sclera, so you need to suspect these kind of changes. If in doubt, get an ERG done. So let me give another example of an abnormal looking retina in an asymptomatic patient. So this patient came for a regular checkup. He was totally asymptomatic. When he saw that my fellow brought this case, sir, patient is symptomatic, I can see so many flecks. Like she said, sir, multiple exudates in the retina. Then I told her not exudates, they are flecks. And the vision was 6, 6 and 6. OCT again, it was normal, all the layers were intact. So this is the ERG. ERG was also normal. So basically this is a benign fleck retina. Okay, you need not do anything. So this is a recessive disorder. So one more patient with similar, not so much of flex, but there were some similar deposits. Vision is again 6, 6 and 6, but this patient had night vision problem. So the first patient was asymptomatic. OCT was again normal. Just if you look at the fulfilled ERG, so there was an unrecordable 0.01 response. And the combined response, if you carefully observe, the A wave is forming. The B wave is supposed to go like this, but it's not even reaching the baseline. It's getting terminated here itself. So this is the classical electronegative ERG, what we get. So if there is any problem with the inner retina, either in terms of vascular or transmission defects, like bipolar transmission, or if the patient has a CRAO, for example, where outer retina is intact, the inner retina is not functioning. So basically you need to think of condition where there is outer retina is intact, inner retina is dysfunctional, you get this kind of electronegative ERG. And one of the most common we see in cases of congenital stationary night blindness. So this was a case of fundus albipunctatus, which is a type of CSNB. So just look at these two cases. Both had, in fact, the first patient, the fundus looked more abnormal, but when you do the ERG, the functionally it is telling a completely different story. So all of us who practice electrophysiology, we believe in one thing. So whatever the retina, however it may appear structurally, so that doesn't mean that it's functionally behaving the same way. Okay. Fine. There's one more example of a normal looking retina with an unexplained visual symptoms. So this was a 26-year-old female who was recently married, got the husband because she was inattentive to the surroundings, and there was no positive family history. So ocular examination, vision, we still don't know what she was giving very variable response, and everything was normal, anterior segment, posterior segment. This is the OCT. I'm showing all the cross sections. It is absolutely normal. There is no defect in any of the cross section in the star scan in both eyes. Again, the autofluorescence was normal. So obviously we thought recently married, maybe she's not adjusted and all that. Everyone thought she's malingering. So before labeling any patient as malingering, I always subject them. It's better to subject them to the electrophysiological test. So we did the the ERG and this is what we got. So our light adapted responses were unrecordable. So this is a case of achromatopsia. So this is the kind of defect what we see in achromatopsia, that the defect which resembles photic retinopathy in the fovea. At least in my experience, saw this kind of thing for the first time where everything was normal. Okay. Fine. So there are sometimes you see patients who have taken multiple concentration. What's wrong with my eyes? People tell there is something wrong in there, but I'm not able to understand what's wrong. So this is one such patient who was a 25-year-old male who presented with night vision problem, no positive family history again. Vision was 6/9. So color vision was normal, anti-segment was normal. So he was born out of a consanguineous marriage. He had one more younger brother. He told he's fine. We didn't examine him, but and this is his fundus photo. So if you observe closely in the posterior pole, there is a kind of a missile-like reflex. So night vision problem, missile-like reflex. I was pretty sure what I am dealing with. So this is the autofluorescence. It's pretty okay except for mild peripheral hypoautofluorescence, which I see in some of the myopic patients also. The posterior pole autofluorescence, if you look at, there are some stipple areas of hyperautofluorescence which were seen if you observe carefully, just along the arcades. So OCT showed some kind of a peripheral stytic changes. So mesophenomenon, some stytic change, I thought, okay, maybe CSM variant or maybe a mild variant of retinosclerosis, all that I was thinking. And I was expecting an electronegative ERG. So this is what I got. So dark adapted responses are grossly diminished and delayed. The light adapted responses had a funny kind of a thing. So my mentor, Professor Gramander, always told, if the dark adapted 3-0 ERG and light adapted 3 ERG, if they look similar morphology, we should suspect something. I'll tell what is that. So we thought of going for some other extended protocols, which Parveen Naiman is going to talk on our talk. So we stimulated the long and medium wavelength cones. So using the green background stimulating with the orange light, it was unrecordable. But when it simulated the short wavelength cones, there was an enhanced response. So basically this is a case of enhanced S-cone syndromes. To conclude, I would like to say the electrophysiology is an important tool to aid the diagnosis of various disease, but it should always be followed by clinical correlation. If we are suspecting retinal dystrophy,